Hi, I'm Dr. Jon Abramowitz, and I'm a professor in the psychology department at the University of North Carolina at Chapel Hill. And I'm very pleased to be presenting on recent advances in exposure therapy for OCD. And in particular, we're going to talk about the inhibitory learning perspective. And I just want to acknowledge these students and colleagues of mine who have really helped me with the research that we've done and helped me kind of think about this topic in the way that I do. And as far as what we're going to cover, we're going to talk a little bit about why we do exposure therapy for OCD, kind of the background and conceptual model. And then we'll talk about how we understand exposure and response prevention, ERP, and the different ways of thinking about how it works. And we're going to spend most of the time talking about different techniques that you can use to optimize inhibitory learning during exposure and response prevention. So let's get started without further ado. So what is OCD? What is obsessive compulsive disorder? So we're talking about obsessions, which are senseless mental stimuli, and they're often triggered by something in the external, environment. So a person sees a knife, and then they think about something like, "What if I stab someone?" And obsessional thoughts go against the person's typical beliefs and values and personality. So it's a gentle person thinking about, "What if I stab someone?" Or someone who prides themselves on being very clean, thinking about germs and contamination. Or someone who prides themselves on, um, I don't know, morality, having some sort of what they perceive to be as an immoral thought. And everyone actually has unwanted, intrusive thoughts that kind of go against their character. But we know that people with OCD, they misinterpret those thoughts as being significant and being threatening. So what if this thought of stabbing someone that I love, what if it means I'm really a murderer? Or what if it means I'm going to lose control and do something terrible? And so they overestimate the threat that's associated with intrusive thoughts. And then in response, the person avoids, or they do compulsive rituals to try to reduce the distress, the obsessional fear that's provoked. So back to my knife example, maybe I'm going to lock up all the knives or have someone else hide the knives from me. Or maybe I'm going to pray over and over again that I don't lose control and stab someone with a knife. And the thing is that technically these kinds of strategies, they work, right? Because the person, of course, they're not going to stab anyone anyway. They pride themselves on being gentle. But they think that it was because of the avoidance or because of the rituals. So it's like a near miss. If I hadn't done the ritual, if I hadn't locked up all the knives, I would have done something crazy. I would have done something terrible. And so these avoidance and compulsive rituals are reinforced by the reduction in distress that they bring about. It's negative reinforcement. The problem is that they maintain the obsessional fear because they prevent natural fear extinction. I have no opportunity to disconfirm my misinterpretation of the intrusive thought if I'm always avoiding or praying. I never have a chance to find out that I could be near a knife and I'm still a safe person. These thoughts basically don't mean anything. And so that leads to a very empirically supported and which I'll show you some data in a second, and conceptually consistent approach to treating OCD. And this was all worked out in the 1950s and 1960s by people who did research with both animals as well as later on with humans. The idea that OCD remits when a person comes to believe that their obsessions are unfounded and that their compulsive rituals don't really keep them safe because they're safe anyway. But you can't just talk the person out of it. They have to act accordingly. You have to get in the situation and find this out for yourself and behave as if you're safe. And as I mentioned, we can't talk someone out. We can't just kind of use, let's say, Beckian cognitive therapy to analyze probabilities and things like that. There's nothing wrong with cognitive therapy for lots of other problems, but for OCD, the person ends up kind of hijacking cognitive therapy and often using it as a ritual to try to analyze, what's the chance that I'm going to stab someone? What's the chance that I'm really contaminated? And so with OCD, the person needs to directly confront their fears, exposure therapy, and drop their rituals, response prevention, to truly be able to master this problem and get over this problem. And exposure and response prevention is the most powerful treatment for OCD. And hopefully you're asking, show me the evidence, right? Where's the evidence for this? And we have multiple randomized controlled trials all over the world showing that ERP is more effective than other credible psychological treatments, as well as it's more effective than medications. Meta-analyses show that exposure therapy for OCD has really large effect sizes. An effect size of 0.8 is large, and we're talking about effect sizes here well above 1.0. And for most patients, they see some short and long-term improvement. Not everyone responds, and not everyone stays better after treatment. And that's going to be important for what we're talking about today. So how does this work? How does exposure therapy bring about these changes? The kind of traditional model for thinking about this is called emotional processing theory. And the idea here is that exposure therapy breaks or weakens the connection, the association, between the conditioned stimulus, the trigger, and the conditioned response, the fear and anxiety. And so, and if you're inclined to read a famous paper by Edna Foa and Michael Kozak from 1986 in Psychological Bulletin, this is kind of the definitive paper kind of defining this emotional processing theory. And what Foa and Kozak talked about was you have to activate a fear structure, so get the person afraid by exposing them to their fear. And then if you keep the person in the situation over time, you'll find that their anxiety habituates. And this happens within the session. So within a 60 to 90-minute period, often, if not shorter, sometimes longer, you'll see that the level of distress, level of anxiety and fear comes down naturally on its own. That's called habituation. And also, if you do exposure to the same stimulus on different occasions, you'll have between trial or between session habituation. And so this is kind of a graph showing, here's session one, let's say exposure to touching the floor for someone who has a fear of contamination from floors. You see their distress goes down over the course of about 60 minutes. And this arrow kind of shows the within session habituation. But if we do exposure again to touching the floor, we get also that nice habituation within the session, but also we can see there's between session habituation. The person never gets as anxious as they were or as distressed as they were during the first exposure. And so over time, theoretically, the distress level comes down each time you do exposure. And again, that's habituation. And it's assumed that if the person with OCD has habituation during the sessions and between the sessions, then the person has improved. So self-reported anxiety during the session, which we kind of affectionately refer to as suds, which is subjective units of discomfort. The idea here is that the person improves if their suds goes down during the session and between sessions. Michelle Krask, however, about a decade ago, if not a little bit more, asked the question of, well, does habituation matter? How reliable of a predictor is habituation in terms of predicting long-term outcome? And clinically speaking, having done a lot of this therapy, and probably many of you have as well, we can sometimes get successful outcome despite a lack of habituation. Person doesn't, their anxiety stays really high the whole time, and yet they get better. And certainly we've all worked with people who have OCD who have nice habituation curves, like I showed you in the graph, but their symptoms come back at some point in the future, or they don't get better. And so one question that we can think about, and one of my former graduate students, now a faculty member at Mass General, Ryan Jacoby, has thought about this a lot from an OCD perspective. Michelle Krask has thought about this as well at UCLA with her colleagues and students as well, that if we focus too much on habituation, there's actually a liability here. So some patients will come in saying, okay, this exposure is going to be really difficult for me. I'm really afraid to touch the floor, but I know that my anxiety is going to go down. And so I'm just going to white knuckle it through the exposure. And then I'm going to, I'm going to do better. And that's really akin to using exposure to control anxiety. And we don't want folks doing that. And one concern is that if we're focused too much on habituation, that is what will happen. And as a result, patients won't really be learning what they need to learn by doing exposure, and that is that the floor is safe. Instead, they'll just be gritting their teeth, getting through it, white knuckling it until their anxiety goes down, and then it's like, whew, okay, I'm through with that. Another liability is that it sends the message, if we focus on habituation, it sends the message that, you got to stay in the situation until your anxiety goes down, and then the session is over, and we got to wait till your anxiety goes down. So it sends this message that somehow anxiety or obsessions are unsafe or intolerable, and you got to stay here until it goes down. Another problem is that, inevitably the person's going to run into, just in the world, sources of obsession, sources of anxiety, cues for these things. And if they get anxious, they're going to misinterpret that as, oh my God, I'm relapsing. This is bad. This is dangerous. I shouldn't be so anxious. Where's the therapist to help me get through this? And we don't want that. And as you're going to see, the aim of the inhibitory learning perspective is to kind of try to circumvent, in part, is to circumvent some of these problems. Now, we know that people with OCD and all sorts of problems with anxiety, even once they have had good treatment, seemingly good treatment, their fear can kind of reignite later on. And we know this is so because there are different types of ways that a fear can return. And one is just a spontaneous recovery where the fear just inexplicably comes back. Another is called a context renewal of fear. And this is where the person encounters the fear stimulus in a new context, different from where extinction took place. So if I did exposure therapy to my patient just in my office, to the floor in my office, but then let's say they dropped, a lot of money or their wallet or phone on the floor, in a movie theater, now they might become, more afraid, even though they had nice habituation in my office, because this is a new context. Boy, I didn't practice this in the movie theater. What if people drop their gum and their shoes are on the floor and all of this kind of thing? We can also have what's called reinstatement or rapid reacquisition, and this is where some sort of adverse event can lead to the return of fear. Obsessional stimuli somehow get repaired with anxiety. And so looking at the return of fear this way, we have ways that we can optimize exposure to reduce the likelihood of the return of fear. And that's really what the inhibitory learning perspective on exposure is all about. So Michelle Krask thought about these pathways to long-term success and developed this inhibitory learning approach and wrote about it also in really two excellent papers in behavior research and therapy. One came out in 2008, another in 2014. And I actually have to give kudos to Ryan Jacoby, again, Dr. Jacoby, and myself. Ryan has also written a nice paper kind of applying the inhibitory learning approach to OCD in particular. And that came out in 2016 in Clinical Psychology Review. And the basis of the inhibitory learning approach is that fear associations actually remain intact during exposure. And what's happening is that the person is learning new safety to kind of go along or compete with the old fear learning. So back to my example of the floor, the person, and I'll show you a kind of a visual example of this in a second, but the person is thinking floors are dangerous, knives are dangerous, things like that. Thoughts about knives are dangerous. And when we do exposure therapy, exposure isn't wiping out those danger associations, those danger cues, those danger beliefs. Instead, the person is generating new safety learning. Floors are safe. Knives are safe. Thinking about stabbing someone is safe. I'm not a murderer. And they compete with one another in the person's mind, I guess. So the basic idea is that the fear beliefs are still kind of lurking back there. And so what we need to do in exposure therapy is we want to lay down the new safety learning in a way that's going to maximize the chances that new learning is going to kind of rise to the surface and inhibit retrieval of the old fear-based associations when the person is in a new situation, like in the movie theater, right? We want that person to say, oh yeah, floors are safe, rather than, oh no, right? The gum, the shoes, that kind of stuff. And so primarily what we need to do in exposure is we need to violate negative expectations. So we want to set up exposures so that we are really proving to the person that their fear-based associations are incorrect. And we also need to decontextualize the new learning, the inhibitory learning. In other words, they need to learn that all floors are safe, not just the floor in the therapist's office. All knives are safe. All unpleasant thoughts are safe whenever they come up. And one way we do this is to use exposure to foster fear tolerance. If exposure and response prevention can instill greater fear tolerance, we're going to help to inoculate patients against that return of fear. You see how that's different than the habituation approach. And so this is relevant to how we set up, how we engineer exposures when we're doing exposure therapy. We want to give the patients opportunities to practice fear tolerance. Patients come into our office saying, you got to make the anxiety go away. You got to make these obsessions go away. I can't stand it. The inhibitory learning approach says, you can stand it. Anxiety, obsessional thoughts, they're safe, they're manageable. You want to learn, and I'm going to help you to learn that you can tolerate anxiety. And so this kind of bring it on, lean into it attitude is what we use. The idea here, very different from the habituation model where we're saying, make that anxiety go away. Let's wait for that anxiety to habituate. Here we're saying, bring it on. And so again, back to this inhibitory learning theory, the idea here is to develop safety-based learning that's going to inhibit the retrieval of the fear-based associations. So one way we can think about that is here we have a deck of cards, and let's say this represents my fear of knives or bathrooms or the floor or something like that. When I do exposure therapy, here I have a little bit of safety learning, and I have more safety learning, and I have more safety learning, and we really want to stack the deck so that the person's new safety learning overwhelms, right, the fear-based learning. This is a cute little comic that I made up. So this guy is thinking, gee, bathrooms are really dangerous. So we do exposure therapy. Oh, look, we have an experience where I went into the bathroom, public bathroom, maybe I touched the sink or the toilet or floor or something, doorknob, and I didn't get sick. Oh, maybe bathrooms are safe. Well, let's do this again, and let's do this in different contexts and really learn that all bathrooms are safe. And let's up the ante and really push the envelope and really learn that bathrooms are safe. And let's practice this over and over and over again in different contexts until we've really learned in different ways that I'm going to show you in a second, that learn that bathrooms are safe, and that overwhelms the old bathrooms are dangerous beliefs. So hopefully that's clear. Again, in case it's not clear, when it comes to this idea of emotional processing and inhibitory learning, we've really got apples and oranges here, different ways of thinking about exposure. By the way, I should say that, we've come a long way, 50, 60 years. We've been using habituation-based exposure therapy, and, this treatment works really well. So I'm certainly not advocating give up on habituation, give up on emotional processing theory. When I do workshops and train students, I tell them that inhibitory learning gives us just more weapons in our arsenal to use exposure therapy. So it's not certainly a replacement at this point in time. In fact, the evidence for inhibitory learning really is still growing. We have kind of evidence that's still in its infancy. And we'd like to see more before we just kind of scrap the old habituation model, which I don't think we're ever going to scrap that completely. Habituation happens, but the goal of exposure from an emotional processing theory is to remain in the situation till anxiety subsides. In inhibitory learning, it's to remain in the situation until the expected catastrophes have been disconfirmed. So until the person no longer expects something awful to happen. And as I've been mentioning, in relation to anxiety, with habituation, anxiety is supposed to go down over time. With the inhibitory learning perspective, we're not really concerned about anxiety. We're not really concerned about if it goes up or if it goes down. We want the person to learn that they can tolerate it no matter how intense or how frequent or how durable it is. Okay, so how do we do this? What are some techniques that you can take away from here and start applying in your own clinical work? The first thing we want to do is think about framing exposure therapy in a way that will mismatch the patient's expectancies, mismatch their fear predictions. So when someone confronts a fear trigger and they expect that some sort of negative outcome will occur and then it doesn't, a new safety association, new safety learning has been generated. Now, in some problems, like let's say spider phobia, right? Either the spider bites you or it doesn't. Panic attacks, either you die of the panic attack or you don't. So it's really clear. And in OCD, we have some immediate consequences. Either I'm going to stab someone if the knife is sitting on the night table and my partner is asleep. Either I stab someone or either I stab them or I don't. Right? That's pretty immediate. But in OCD, we also have these long-term fears. What if I get cancer in 40 years because I walked past, the construction site and I might have inhaled some toxic chemicals? Right? So how are we going to manage that? And what about unknowable consequences? Unknowable feared outcomes. Am I going to go to hell when I die? Right? Well, no one alive can guarantee you that. Even the most pious of people can't guarantee that. They're still humans. And at the end of the day, with both long-term and unknowable outcomes, what we have is uncertainty. And in OCD, and again, Ryan Jacoby has written about this. In OCD, essentially what those long-term and unknowable fears boil down to is an intolerance of uncertainty. And so an expected negative outcome for OCD patients is often, I can't live with that uncertainty. I can't tolerate that uncertainty. And so we want to set up exposure therapies, exposure trials to help the person learn, yes, I can tolerate that uncertainty. I'll talk about how we do that in just a second. Similarly, in OCD, we have these intolerance of unwanted or unpleasant internal experiences. Sometimes they're referred to as not just right experiences. Sometimes it's just the anxiety itself, the arousal itself, as you might see in panic attacks. What we want to do, as far as how do we put this into practice, is what Michelle Krass calls expectancy tracking. So we're going to really set up the exposures to violate the expectations. We're not going to worry about suds. We're not going to worry about anxiety. And so we can ask the patient, how strongly do you believe that you are going to get sick if you touch the floor today? For someone who has concerns about uncertainty, these long-term outcomes, how long do you think you can go without asking someone for reassurance? How long do you think you can go without checking the internet to see if such and such is toxic, or without praying to God about the unwanted thought that you had about something immoral? And we can ask patients then to kind of summarize what they learned when they do the exposure, and they're able to manage longer than they thought. So let's stand by the construction site for 10 minutes. If the person said, I could only stand there for 5 minutes before I absolutely, have to leave. Let's see if we can do it for 10 minutes. Oh, you made it for 10 minutes. How about for 20 minutes? How about for 30 minutes? Oh, you were thinking about, some blasphemous thought and you didn't pray and you thought you would only be able to do that for 5 minutes. Boy, it's been 10 minutes now. What can we do it for 15 minutes or 20 minutes, and helping the person to kind of stretch out the length of time that they can resist that ritual, that they can manage the uncertainty. And when you do that, the person learns, hey, maybe I'm better at uncertainty than I thought. And maybe the fear of getting sick is not as valid as I thought. Maybe I'm wrong about that. Maybe it doesn't happen that way. And then again, you really want to consolidate learning by asking the patient and focusing on the discrepancy between what they predicted and what occurred. We actually have a form that we use for doing this, and it appears in a book that I just published, actually just came out earlier in 2019. It's by Abramowitz, Deacon, and Whiteside, Brett Deacon and Steve Whiteside. It's called Exposure Therapy for Anxiety, Principles and Practice. It's by Guilford Press. And it's a second edition of a book that first came out in 2011. And this newly revised edition includes a lot more information about inhibitory learning. And we discuss all of this in detail. So if you like what you see here, then you might want to read a little bit more about that. Some shameless self-promotion. Another thing that we can do practically is to combine fear cues. If you're a good exposure therapist, maybe you're doing this already, but you might not think about it this way. But Robert Rescorla came up with this term deepened extinction, which is the idea that when an expected negative outcome fails to occur despite the presence of multiple fear cues, the person's going to learn safety more strongly than when it's just a single fear cue present. So, for example, what are the fear cues for OCD patients? Well, contaminants like doorknobs, leaving the house, and bad luck numbers like 13 or 666. But people with OCD also have cognitive fear cues, obsessional thoughts, images, doubts, impulses, things like that. And there's physiological arousal, right? Is it anxious arousal or sexual arousal when I looked at that child? And these not just right experiences. And so I'm going to show you a slide in a second, but we can combine these and actually make exposure more powerful. So one way we could do that would be to combine imaginal exposure along with real situational exposure. So let's touch the public toilet, and then let's think about the diseases that you could get. Let's think about those germs jumping around on your body, and let's go eat some M&Ms now with your hands, and think about all the terrible things that could happen, right? So you're combining fear cues. We could also do external fear cues, cognitive and physiological. So this is for someone who has intrusive sexual thoughts about dogs and unwanted, sexual images. Pet a dog, imagine engaging in sexual behavior with the dog, and allow yourself to feel any arousal that you experience. It might be anxious arousal, of course, but help the person to be able to have all of those fear triggers at once, rather than just one at a time, just situational exposure or just imaginal exposure. And one, I think, technique that should be used more, that could be used more in the treatment of OCD, a lot of therapists overlook, is interoceptive exposure. Because lots of folks with OCD are afraid of their physiological responses, just like we see in panic attacks. Another technique we can use is what's called linguistic processing. And this is getting the patient to speak about how they're feeling. Another term for this is affect labeling. There is research to suggest that this aids in the development of non-threat associations. Now, this is different than cognitive therapy, so we're not going to challenge or change the person's appraisal. So if the person is saying, I'm really terrified that I'm going to get sick from touching the floor, you're not going to jump in with, well, what's the probability of that, right? Where's the logic in that thought? You're not going to use those key questions. Here, you want the person to actually focus on their threat-based beliefs. That's going to help us to be able to disconfirm those. And so the clinical implication here is, as I was just mentioning, having the patients put their feelings into words, right? I'm feeling scared that reading about pedophiles will cause me to want to molest a child. We want them to say that. I'm afraid that when I touch the bathroom floor, I got urine and feces germs on my hands. I feel uncertain of whether God is angry at me for thinking curse words while sitting next to the Bible. We want them to verbalize that, vocalize that during exposure. Another thing that might do, by the way, is to continue to provoke anxiety and help the person to see that they can tolerate anxiety. They can tolerate those intrusive thoughts. Another technique is to maximize exposure variability. And Bjork and Bjork have written extensively about the role of context and the new theory of disuse. We know that when we introduce variability into exposure, it makes short-term learning more difficult, right? Because the person has to do the exposures over and over again in different contexts, learning new stuff. But that's going to enhance the long-term retention of safety learning. And we like to call this desirable difficulties. So there are different ways that we can introduce variability. And so there's a couple clinical implications here. The first is to vary the exposure intensity. Now, let me say a few things about gradual exposure and the use of the hierarchy. In our clinic at UNC, we train our exposure therapists that they don't have to use gradual exposure. They don't have to use a hierarchy. In fact, we call them exposure lists rather than exposure hierarchies. Why is that? So when you set up a hierarchy, that kind of implies a couple of things. Number one, it implies that we have to have habituation to one exposure item before we can move on to the next more difficult one. And so this goes along with the over-reliance on habituation. It also sets up the expectation that lower level anxiety is safer or is easier than higher levels of anxiety. And that's just not true. Anxiety is anxiety. It's your fight or flight response. It's not going to hurt you if it's a little bit. It's not going to hurt you if it's a lot. And we want our patients to learn that. And so we don't want this, implication that, oh, I'm not ready to do those higher items on the hierarchy yet. I'm not ready for that kind of anxiety. And the thing is that this can reinforce more fear of those higher items, just because, we got to put those off till later on, if that's kind of how the therapist is structuring it. The other thing that's not on here is that in the real world, like, life is not structured according to a hierarchy. When the person with OCD walks out their door, they could be hit with their most intense anxiety-provoking situation right off the bat. And many are, if they are afraid of, urine and feces and they use the bathroom every day, that might be their most intense exposure. And so real life isn't built around a hierarchy. We should probably structure exposure more like real life. And so an alternative approach is to use a varied approach to exposure. And by the way, so how would we do that? We would vary the intensity of exposure. So maybe we're going to have the person pick out of a hat, right? And select at random where, are we going to do a high item, an item that provokes a lot of anxiety, an item that provokes, less anxiety. And this is going to teach the person that they can tolerate exposure across a variety of emotional states. They get more opportunities for surprise, and we know that surprise helps with inhibitory learning. And like I mentioned, it prepares them for real world settings. So again, one way to do this literally is select out of a hat, right? You can also set up exposure based on functional interference. So let's work on the things that interfere the most with life first, regardless of what their anxiety level is. Again, we've come a long way with hierarchy-driven exposure. So I'm not saying completely ditch that. And there might be some patients who, are going to do really well with that. There might be others that you can push to do this kind of more random approach. So Ryan Jacoby actually did her dissertation on the comparison between random and varied versus hierarchical exposure for obsessional thoughts, and she didn't find a difference. So we don't necessarily have strong data that one is better than the other. Another implication here is to vary the exposure context, and I think this one is really important. When we practice learning anything really in different contexts, different settings, that enhances the accessibility and retrieval of what we're learning. We just have more opportunities to have more cues that help us to recall what we're trying to learn. And so in practice with exposure, we want patients to do exposure in as many different contexts as possible. So this means varying up the situations and the stimuli. So don't just do exposure to the bathroom in the clinic. Go out and do it to a bathroom on campus, or in a restaurant, or at the mall, or in a bathroom. In a gas station. Another context is the therapist being present. When you're there with the patient, and I'm sure you've had patients tell you this if you've done this before. Well, when you're here, it's easier to do. But if you were, when I'm at home, it's a lot more difficult. Yeah, because you're a context. You're a safety cue. And so make sure the patient's practicing without you. Medication can be context as well. And this is perhaps a whole nother talk that we could do, the importance of medication causing a context, especially benzodiazepines. Think about people with panic attacks. Just knowing that they have that pill bottle in their pocket and could take their benzo when they start to feel anxious, that creates a context. They're able to get on the bus. Then they're able to go driving. But if they leave their medicine at home, that they're in a different context. They feel unsafe. And so having an SSRI on board, having a benzo available, this does create a context for exposure with OCD. Time of day, day of the week, also a context. I'm working with a patient now who has no problem driving around malls during the week, during the day, because there are just not as many people there. Most people are at work. But on the weekends and at night, and especially during the holidays, he won't go driving near malls because there's more pedestrian traffic, and he worries about, what if he loses track and hits someone. So again, we need him practicing different days of the week, different times of day. And aiming, of course, for practice in situations where the symptoms are most likely to be triggered. But you never know when OCD symptoms can come up. And so the broader the context, the better. Another implication is varying up the practice interval. So temporally spacing the learning trials, research shows, can result in better long-term retention because the person has more opportunities to strengthen their long-term memory because they forget and they have to practice relearning associations. And we can do this clinically by maybe expanding the scheduling, the spaces between the sessions. First, you're working with the person twice a week, then maybe once a week, and then maybe every other week, and then maybe once a month, things like that. This one, if you're familiar with OCD, this is kind of a no-brainer, but response prevention is critical in the treatment of OCD. Some research long ago by Edna Foa, Gail Steketee, John Grayson, and others found that if you do exposure without response prevention or response prevention without exposure, you don't get as good short or long-term results as if you combine them together. And we know that compulsive rituals interfere with mechanisms of inhibitory learning. When the person does a ritual, it prevents that violation of negative expectancies. If I sit on the floor for an hour and eat off the floor, but then I go immediately and wash my hands, that's not a good example. Let's suppose I sit on the floor and touch the floor for an hour, and then I go and wash my hands before I eat, then I am not able to learn anything. I'm never, when I eat and I don't get sick, I'm just going to learn that as long as I wash my hands, I'm okay. So I need to sit on the floor and then eat without washing my hands to learn that the floors generally aren't dangerous. The other thing that compulsive rituals do is it prevents the decontextualization of inhibitory associations. So if I'm always doing rituals, that presents a context too, right? I'm safe because I did the ritual. And we want the person to learn that they're safe even if they don't do a ritual. Rituals also prevent the development of fear tolerance. So if I'm always ritualizing and reducing anxiety, then I never have a chance to learn that I can do anxiety. Anxiety is not dangerous, and it actually is temporary, and it will eventually go away. But I can manage it, and I can operate even if I'm feeling anxious. So we need to continue response prevention. It's okay to go at the patient's pace, but some pushing is important. We can do gradual exposure. We can do, gradual response prevention. We can do hierarchical response prevention. But it really is important at the end of the day for patients to not do rituals after they've done their exposures for the reasons that I just described. And one way to get buy-in on this is to really provide a strong rationale for both exposure and, of course, response prevention. One of the things that I find when I do workshops and therapists, ask me, how come I can't get patients to do exposure, to do response prevention? When we talk about it, it turns out they haven't given a strong enough rationale. They haven't tied the use of this treatment into the conceptual model of OCD. And so the patient doesn't really understand how to get the most out of it. They don't understand why they're doing the therapy. I just think that's so important. So that's all I've got. Again, some more shameless self-promotion. These are two books that kind of go into more detail about the inhibitory learning approach for OCD. Um, and so I'll leave you with that. And I hope that you've enjoyed this presentation. And thanks for tuning in. Bye-bye.